Okay. Hello, everyone. Welcome back to Kokoro. For today's session, we have Dr. Abhimanyu Chandak with us, and he will be helping us understand dementia from a more biological perspective to get an understanding of what's behind all the deficits seen in the disorder. So similar to last week, Dr. Abhimanyu will first take us through his presentation for the first 20 minutes. And then we'll follow that up with a 20 to 25-minute Q&A session. We want to keep a longer Q&A from last time so that everyone's questions get answered. And we are recording the session, so you will be able to view it later on as well. Now I would like to introduce our speaker for today, Dr. Abhimanyu Chandak. Dr. Abhimanyu did his MBBS from Jawaharlal Nehru Medical College in Karnataka. And he did his MD in psychiatry from JSS Medical College and Hospital in Mysore. He worked under the guidance of Dr. Rajesh Raman and Dr. T.S. Satyanarayan Rao. And he's now working as a neuropsychiatrist at Viveka Clinic and Hospital in Mysore. Thank you so much for joining us and being a part of Kokoro, Dr. Abhimanyu. I'll hand it over to you now.
Thanks, Kriti. Thank you so much for the opportunity. So, how many of you are on your phones? I really hope not too many. Okay. If you're on your phones, there are a couple of pictures that might be a little difficult to look at because it's something that you really need to see to understand. So I would really suggest that if you can move to a bigger device, that would be much better. If not, it's all right. We'll continue with it. So yeah. So why don't we try that? Yeah.
Are you able to see my screen? Are you able to see my screen?
Can you see if I draw, Kriti?
Yes, I can.
Okay, wonderful. Okay. All right. So we'll start in another 2 minutes once people have been able to shift to a bigger screen, because I really feel that's an important thing. Yeah, if you can, that would be great, Suchati. All right. So while people are moving to a bigger screen, everyone's had an introductory session on what dementia is, and I think Dr. Chawla has gone into a lot of detail and explained how dementia progresses. So I'm really not going to get into too much about dementia as such, and the reason for that is that it's not that simple to understand what happens in dementia. It's much easier if you understand how the brain works, because as Dr. Chawla mentioned, that dementia is just sort of an accelerated process of normal aging because of various factors. So in normal aging, there is shrinking of the brain. In dementia, it's either too fast or happening from the wrong direction or happening because of the wrong reasons. So depending on which area of the brain gets involved, the symptoms will be seen. So if you can understand the brain and what these areas are, what its common functionalities are, it's much easier to understand what happens in dementia and why it happens, right? So Kriti, can you move to the next slide? So beginning off, dementia has bunch of symptoms, and it is as confusing as this sort of word salad here looks like. It can range from anything from things like apathy to crying, anger. It can go from suspiciousness to delusions to and hallucinations. It can go from just slight forgetfulness or memory disturbances to full-blown amnesias. It can go from just simple not forgetting how to do things, simple tasks, to bad apraxias, having aphasias, unable to speak, not remembering how to speak, not remembering how to swallow, you know, not remembering how to identify objects. So while I say not remembering, it's not a problem of memory, right? Although I'm using the term not remembering, it's not because they've lost the memory of how to recognize things. They've lost the ability of how to recognize things, or they've lost the ability to plan how to do things. It's not that they've forgotten how to do things. So it's not just memory. Although we say they don't remember how to do it, or they don't remember what it is like, or they don't remember the face, it's not just memory. They've forgotten how to recognize, they've forgotten how to actually plan and do things, right? And that's because of the area of the brain involved. So there's a bunch of symptoms here, and I'm sure all of you have experienced it. And I always feel that symptoms and signs are better discussed uh, in sort of a discussion manner in a question and answer session. So we'll get to that in the end. I don't want to bore you with it. So just let's move on to the next one. So to understand dementia, as I mentioned before, we need to really understand the brain first, right? So that's where I'll be spending most of my time, as to how the brain is, how it functions, and what are the various areas. Then we move on to what happens in dementia. Very, very briefly, Dr. Chawla has already gone into this. Then next we move on to some of the common mechanisms that can cause dementia, lead into dementia. And then we move on to why dementia is progressive. I'm sure you've heard this from most of your doctors, that they tell you that dementia is a progressive illness. There's nothing we can do to stop the progress. There's nothing we can do to reverse it. So why is it so? Very simply, in 3 or 4 points, I'll try to explain that. And finally, we'll look at something which is a little more preventive and maybe can help improve the symptoms to some extent, which is the cognitive reserve. All right. So moving on. So first thing, understanding the brain. This is how your brain looks, very, very animatedly shown here. It's much, much more disgusting when seen face to face, very slimy and covered with fluids, the fluids inside it, fluids outside it, lots of coverings, lot of safety precautions. And despite that, it is so prone to damage, and once damaged, so difficult to heal. So if you look at it here, so the brain has various regions. This part, this area, which is blue, red, green, and orange, this is something called as the cortex. So as you can see, the cortex has, various areas. Again, it has the frontal lobe, it has the parietal lobe, it has the occipital lobe, and it has the temporal lobe. Each lobe has its own sort of function, also has its own areas, own connections, neurotransmitters, different level things, right? So that's the cerebral cortex. Then you have something called as the other brain structures, which are called the central brain structures, which is called as the mesencephalon. Very technical term, need not get into it. This contains more of something called as your limbic system, which is connected to your emotions, your hypothalamus, which is connected to your memories, right? Then these black structures that you see here, these ones, right? This is your something called as your ventricular system, which basically drains out. So in our body, we have oxygenated blood going through the arteries and deoxygenated blood coming through the veins. Here, some of those fluids are drained into something called as the ventricles, which forms something called as the cerebrospinal fluid, which is a protective fluid around the brain to prevent it from physical damage, right? So that is the ventricular system. And don't worry, I will move further into it later on. The cerebellum is mainly responsible for our balance and to plan out what all balance, to maintain sort of muscle stability when we are standing, when we are shifting limbs, when we are throwing objects, things like that. That's where the cerebellum comes in. Then you have these two structures called the pons and the medulla. There's another structure above it called the midbrain. These three structures are actually responsible for most of our what we call as the face nerves of the head and neck. So our whole face control lies within this area mostly, which includes the sensory as well as the motor aspect. Plus, the pons and the medulla also contain centers related to breathing, related to your heart beating, right? And the medulla later on continues down below as the spinal cord. So these are the main structures. What we are going to focus on right now is the cortex, because when we talk about dementia, as Dr. Chawla had explained last time, there's something called as cortical dementias and subcortical dementias. We will not be getting into subcortical dementia as much, because irrespective of where it starts, in the end, it progresses into the cortex, and understanding the cortex is much more important. So within the cortex, there are, as I said, multiple lobes. So very simply, we have divided the lobes. And these lobes are further to be understood, put into someone's mic is on. I'm getting this thing echo. Can someone please mute them? Yeah, that's perfect. Thank you. So it has other areas. So these are called as Brodmann's areas, and each an area has a specific function. So let's focus here, if we want to, specifically on the motor functioning area over here, right? So this part, this 3 over here, which is there, along with the small 3 and the small 3. So these are all various views, right? So this is from the side, this is from the center. So this one is from the side, this is from the center, and this is from up top. Okay, so everywhere you see the 3 is the motor function area. Okay, so it's a small sliver that goes all throughout, and our body is represented in a very weird form across this whole sort of how do I describe it, sliver of the brain. Okay, depending on which we function most. So our lips, our fingers, right, these have the our tongue, these have the maximum representation. So they are big, huge areas within the motor cortex, whereas our back, our abdomen, right, these chest, these all do not have as much of representation, because there's not much movement that you do there. This area that you see 9 over here, this is the sensory part. So this is again similar to 3, the structure remains similar to 3. It's right behind it, and that's responsible for us to understand what we are feeling, whether it's pain, whether it's touch, whether it's pressure, whether it's vibration or whatever it is. All of it is interpreted there. So these are the 2 ones which are physically seen. Now what we move on to this part of the cortex, so which is the frontal cortex. The frontal lobe, as you see, has again different parts. But the frontal cortex main function is something called as higher mental functions, which means, as you can see here, it says judgment, concentration, right, emotional expression, creativity. So all of this comes from here. So I think, again, I'm sure Dr. Chawla must have mentioned there's a type of dementia called as frontotemporal dementia, where the frontal part is involved more. So whenever this area gets involved, you will start to see that the person does not have judgment. They will start to do things which are completely wrong and not even realize that they are wrong, right? They will start to have disinhibited behaviors. They will not show expressions, or they will show too much of expressions. Basically, it's the higher control center. When you have an impulse to do things, this is the center that says, wait, this is not the right time to do it. You can do it later on. And you see what a huge representation it has. So even a small damage in, say, this part, or a small damage in this part, will lead to some amount of sort of disablement within this particular function. So that's the frontal lobe. So the temporal lobe, when you look at it, the main function of the temporal lobe is, other senses, the 5 senses that we talk about. So hearing, smelling, right, taste, all of this comes here. But when you move into the temporal lobe, or say behind the temporal lobe, where the mesencephalon lies, which is this area, which I talked about, the hypothalamus and the limbic areas, this part is mainly responsible for your emotions and your memory. Okay, so apart from that, I don't think we will get into too much of this. Can we move to the next slide, Kriti? Right. Now, the reason I added this slide is because a lot of my patients ask me, why these are the functions that go, or these are the functions that go post-stroke. You must have seen people developing dementias, or, when I explain to them that how hypertension can be a factor in dementia developing, or how diabetes can be a factor in dementia developing. So as you see, if you can make out these blood vessels, they completely end here. They don't connect with anything else, right? So once they reach the ends, they just completely finish there. Okay, so they completely end there. So since they do not have any further connections up there, what happens is that if there is even a small block here, there will be nothing else to supply that area of the brain. Because of that, the damage is much more in these areas than in areas like these, where there are multiple branches over there. So these areas of the brain, which have some of the motor centers and some of the sort of the memory centers and all lying over here, you see the blood supply is very minimal there already. So even a small damage will cause a lot of problems. Okay, next slide, Pratik. Right. Now, the reason I've put this here is when we look at a scan, right? So the ventricular system is like a balloon which has been entrapped inside a hard object. Okay. So if this hard object starts to shrink, the balloon will expand. As the balloon expands, it puts pressure on areas around the ventricle, right? So these areas around the ventricle are most prone for damage the moment the brain starts to shrink. So while the brain has all its matter and is maintaining itself, its shape, these ventricles are bound there and kept there very tight. The moment it starts to shrink and give way, which will happen as you're getting old, right? Your structures get weaker. These ventricles start to push against the brain and start to cause damage around it. So a lot of times we see that the damage starts around these areas, and around these areas is where you have your control of urination, control of defecation, your memories here, your short-term memories there, your emotion centers are all there, right? And then if it progresses to some part over here, then you start to see that the swallowing starts to get affected, the breathing starts to get affected, right? So this is the importance of the ventricular system. Next one, Priti. Okay. The first, foremost, and most common symptom that we see that people come to us with is that this person is forgetting things. So I'll not go into the technicality of the memory circuit, but as I was saying, if you look at the areas that are there, right? Again, I'm focusing on the areas because I want you to understand that if this area is affected, they will have this symptom. If this area is all right, they will not have this symptom. So it's not absolutely necessary that everyone has memory deficits or has. But the reason that this area is most commonly affected is because the blood supplies end here. There is no branching further, or there's no branching into it from the other side. The blood supply completely ends there and just remains there. So if there is a block here, there's no blood reaching that area, and that leads to these short-term memory losses, right? Plus, the second thing, these areas are around the ventricle. So the ventricle starts to push, and even a small damage here is going to lead to memory loss, right? So our memory functions very simply. Our memory goes around the circuit repeatedly. The more number of times it goes around the circuit, the stronger the memory, and then it is stored in these corners, which is called the neocortex, right? It's stored all around. So now, if there is a damage happening somewhere here, since the memory has been distributed all throughout, only a small portion of the long-term memory is lost. But same thing, if I draw the same circle, same size of circle somewhere here, then the number of I draw the same circle, same size circle here and the same size circle here. As you can see, the area of the brain or the number of neuronal circuits, as it goes out, it spreads out like this. So here there are 3, but here there's only 1. So the damage also is much, much worse if something happens in this area concentrated here rather than happening up here, right? So that's about the memory circuit. Next, right. This is another circuit of the brain, not very important, but it basically controls our motor functioning. So our planning of actions. So for example, if I ask you to say simple things like pick up a pen, put the cap and give it back to me. For you, it seems like such a simple instruction, but for the same person, a person with dementia, it's going to seem like such a big task because they are unable to plan it. You give them simple things, pick up the pen, now put the cap, now give it to me, they will do it very easily. But you give them all 3 instructions together and they'll get confused. They will like either try to put the cap first, or they will try to give you the pen without putting the cap. They might jump to the end. That's because they have difficulty in planning because of an effect in this area. And again, you see this is around the ventricles. So this central area around the ventricles is very, very prone to getting damaged, especially in dementia. All right, Kriti, can move to the next one. Right. Talking about neuronal circuits and neurotransmitters. Now that was the structural part. That was the anatomical part, right? That is something that we can see. This is something that we cannot see. So one of the main neurotransmitters which are present in the brain, and when I say neurotransmitters, I don't know how many of you have a science or a physics background, but very simply, our brain runs on electricity, and here electricity is not transferred in the form of electricity, but it is transferred in the form of these neurotransmitters, which go from one neuron up here to the next neuron down there. And then there is something called as receptors, right, on which it sits. And while it sits on, when it sits on the receptor, it causes influx of ions like sodium, potassium. These are charged things. The moment you say charge, there is electricity. Okay, so, and that's how electricity passes from one neuron to the next. So these neurotransmitters, especially acetylcholine, becomes very important because you need it for continuous communication from one neuron to the other. Now, what happens in a person with dementia is acetylcholine decreases due to various reasons, and we'll get into it in the next slide, because of which you get most of the symptoms, especially in Alzheimer's. There are other neurotransmitters which are like dopamine, serotonin, there's glutamate, there's GABA. Some of them are activating, some of them are deactivating, and a balance between these is what keeps us functioning in a normal fashion. And the moment one goes down, the other one tries to compensate for it, or this goes up, the other one comes down in compensation. And this sort of disbalance is what also causes a lot of symptoms of dementia. Neuronal circuits wise, I talked about 2. I talked about the Papez circuit and the basal ganglia circuits. These are the ones that Papez is responsible for your memory. The basal ganglia is responsible for your planning of movements, and the limbic system is responsible for your emotions. Okay, so I really hope I was able to get something across regarding the brain. I know it's very confusing, but to put it very simply, the brain has different regions. Each region has its specific function, and depending on which area gets involved, you see symptoms. It's as simple as that. Can we move to the next slide, Shruti? Right. So that's what I've been saying. What happens in dementia? The brain is already shrinking as we age, right? There are other detrimental mechanisms which accelerate or augment normal aging, which leads to either earlier onset or increased severity of symptoms. And depending on the brain area that's getting involved, you see a specific type of symptom. So if you can just look at, can we go back, Kriti, just for a second? Yeah. So if you look at these two, these are what we call as MRI scans. And as you can see in these MRI scans, that all we are able to look at is the structure. So we can't really assess what is happening to the neurotransmitters. We can't really assess what is happening to the neuronal circuits, because we can't see any of those. We have to make an assessment just from our knowledge that acha, haan, theek hai, maybe this area is involved, so because of that we are able to see things. So all right. So if you see these two dark structures here, these are the ventricles. Okay, the gray area that you see all around it is the normal brain. Okay, now in a normal person, in a person who's doing absolutely fine, this gray area will be covering most of it. You will hardly see these black areas or even these black areas on the outer edge, right? These black areas on the outer edge also will be minimal. Yeah, I'm sorry. Been trying that, but oh, there it is. Thank you. So yeah, at the outer edge, if you see these areas, these are also black, right? They are also supposed to be filled and gray. Even these sort of things, these are normally present, but not so wide. Okay. Same thing with the ventricles. They're not this wide. They're not supposed to be this wide at any age. So this has caused compression. And if you can see further, let me show you here. Okay. So if you can see further here, there's a slight whitening around the edges. Okay. So that whitening is because the ventricles have pushed against the brain and caused damage, which the brain has now filled it. Instead of filling it back with neurons, the brain does not have extra neurons to fill it back. It fills it with supporting tissue. And this supporting tissue does not have the same amount of same ability to conduct electric impulses as neurons. And because of that, you start to develop symptoms. So mainly what I wanted you to see is that this is how a brain with dementia looks like. And depending on the areas which are darker, which are more black, the areas that we filled are not filled out very well, we are able to assess how the patient will progress and how the patient will sort of have symptoms in the future. But let me tell you something, this patient functionally came to me in a very, very good state, but the degree of damage that you see here is completely not at all proportional to what I saw on the when we did an official assessment. So that means there is something else also, and which is where something like an fMRI or a magnetic spectroscopy would help us, because we would then know the neurotransmitter levels. We would know how the neuronal circuits are firing, whether they're functioning well. Maybe there are compensatory neuronal circuits that have happened, right? Okay, let's move on to the next slide. Right. All right. So some of the common mechanisms. So the first one is called as the amyloid cascade hypothesis. So there are normal proteins in our body. These proteins are usually stored in a folded fashion, which is what is over here, which is a normally folded protein, right? That's a properly folded protein, so it stays normal. What happens is either due to some kind of a trauma, or say because of some factors, some genetic factors, or some other vascular factors, there's been a stroke or there's been something, the protein starts to clump rather than getting folded. It's sort of like if you fold your clothes and put it into a suitcase, it takes lesser space, it's much more organized. The same clothes, if they're clumped together and just thrown into the cupboard or thrown into the suitcase, it's going to cause you a lot of trouble. So it's the same thing here. The properly folded proteins are no trouble at all, but these toxic protein clumps that are there, these will the ones that will cause a lot of damage and cause, go get deposited in neurons, prevent the neurotransmission from happening properly. And there are a few types, plaques and tangles, and I will not get into that. Just wanted you to know the names. The next one is the cholinergic hypothesis. And as I was saying, so this is a normal cholinergic neuron. You can see the amount of acetylcholine in there, which is the green dots, right? The receptors are all filled and it's functioning perfectly. The same thing if you look at here, even in early Alzheimer's, you see that the amount of acetylcholine itself is less, and not only is the amount less in what we call as the synapse, that is the area between the two neurons, but it's also less within the neuron. right? So it's not just that acetylcholine is not being released. In fact, this chemical is not even being produced as much, right? And this is important from a treatment perspective also. And we'll hopefully get into that in the discussion. Then there are environmental factors, head injury. If there's an injury not repaired well enough, depending on which area is involved, you will have symptoms of dementia. Vascular factors, say you're hypertensive all throughout, right? So if you're hypertensive and this is your blood vessel, okay, and you've been pushing high volume of blood all through it throughout your life, and what's going to happen is, firstly, the walls are going to thin themselves out over the years, right? Secondly, the blood vessel is going to get used to that much of pressure. So say if I put 3 arrows, this is what you were normally doing. As your body starts to age, you're only able to push 1 arrow through it, right? With the blood vessel walls being weak here, this blood vessel is going to collapse because it does not have enough flow within it. And when it collapses, that area of the brain does not get enough blood. And then that leads to damage, that leads to dementia, which is why hypertensives are more prone to dementia. If you look at, say, someone having diabetes, then there's possible deposition of, say, cholesterol within these areas. It's I will answer that question later. That's a good question, whether it's the same as stroke or not. I will answer that in the end if you don't mind. Then with inflammation, again, if you've had a brain disease, blood has been blocked, there has been damage to the brain, it's not repaired properly. We'll get into diabetes also later. Diabetes causes decreased amount of glucose within the neurons, because of which, again, there's not enough energy to produce neurotransmitters, and that can lead to dementia, which is why a fluctuation of blood sugar levels, sometimes very high, sometimes very low, both of them are detrimental and both of them cause harm to the neurons. Next, this thing, yeah. Then there is the brain reserve and the cognitive reserve theory, and we will again get back into that in the last slide because I want to go into depth in that. Next one is, okay, yeah, psychiatric illnesses. Most psychiatric illnesses, what we need to understand here is that most psychiatric illnesses cause a variation in the neurotransmitter levels. So just as in diabetes, there's an increased sugar, there's a decreased sugar. What happened with psychiatric illnesses is either there's an increase in a certain neurotransmitter or there's a decrease in a certain neurotransmitter, even if it is corrected. If there is a person who's having repeated depressive attacks, if there is a bipolar person who's having repeated mood episodes, or a chronic psychotic illness, there is continuous variation in the neurotransmitter levels. And this leads to a lot of damage within the system, which is not visible structurally, but functionally, the system is not working well enough. So repeated psychiatric illnesses, untreated psychiatric illnesses which have not been completely corrected, these are all risk factors for developing dementia. Lastly, genetic factors. While it is not necessary that genetic factors play a very strong role, there are certain genetic factors which influence all of the above mentioned mechanisms and also are sometimes directly involved in causing dementias. So we need to always be careful that if a family member has dementia, we are much more prone to develop dementia and we need to take preventive steps. So moving on to the next slide, as to why is dementia progressive. So as I said, it's accelerated normal aging, right? So your brain is already shrinking, right? That's normal. That's going to happen to all of us. We do not have any control over it. Now, suppose you are shrinking something and I end up putting a pin, or say I start to deflate it from the other end also. What's going to happen is, despite there being the process of aging is continuing at the same pace, but the symptoms are so much more because there is another direction in which it is started. So whatever reserves you had, that itself is decreasing. For example, let me give you an example of there is already water in your bathroom, right? And then there is a leak. If there is a leak, the water is going to keep increasing unless you stop the leak. You're not going to you're not going to be able to, I know I'm giving a very, very bad example because you could stop the water everywhere else, but say there is a reason that you cannot stop the water and your bathroom is always wet. And that's what happens with normal aging. The bathroom is always wet, and now there's also a leak. And now because there's a leak, it gets more and more and more and more every time. You feel that it's much more every time that it happens. And this cannot be reversed. We cannot reverse the normal process of aging yet. If we could, oh Lord, we could have just had like, we could have lived forever if we could do that. So that's something that's not possible, and which is why dementia is progressive. Once the damage starts, even if you can control the damage, slow down the damage, slow down the acceleration to a certain extent, you cannot stop normal aging. So whatever damage is there will start to look much, much bigger because of the aging process. The second thing is that the brain does not really heal itself very well. Despite being such an important organ, unfortunately, the brain replaces neurons with this supplementary tissue, which does the job but does not do it very efficiently. So that's another problem. And the third thing is that if we say try to modify this, if we try to modify the way the brain heals itself, the problem is there are a lot of other body parts which also heal itself in the same way and continue to function well. If we start to hamper or tamper with those, then the rest of the body gets damaged while you save your brain. So it's a very, very delicate process, and which is why it's been so tough to find medications, to find disease modifying drugs for dementia. So we'll move to the last slide, which is the cognitive reserve. Very, very simply, in one line, your cognitive reserve is the mind's resistance to the damage of the brain. So remember the case I told you about, that despite the damage, she's doing very well. This person was, functioning very well, quite well for the amount of damage that I saw. So that is the difference between brain reserve and cognitive reserve. So brain reserve is basically the structural part, the functional part, in the sense that whether you have the number of neurons you have, the number of neuronal connections you have, the amount of neurotransmitters you have, right? So brain reserve is something that's very, very difficult to measure because you need specialized scans and it is very difficult to interpret. But cognitive reserve is more of how well are you functioning. So for that, there are very specific assessments, there are very good questionnaires, and you can assess that, right? So you can look at, despite the brain say having so much of damage, this person's memory is still 70% intact. So there might be 50% damage to the brain, but the person's memory is 70% intact. So that means there were cognitive reserves of 20% there, right? That's what it is. So certain factors that help us build cognitive reserve. So the education and occupation of the person. So if the person, the higher the level of education, the better the cognitive reserve. Does not mean that people who are doctors or lawyers or who have studies, who have PhDs, degree is not equal to not getting dementia. That's not at all what it means. When I say education, it means that you continuously keep learning something. So the more you learn continuously, you don't stop learning, and that's where that's the important part. You keep learning something new. That's what I mean by education, not that, oh, ye degree, then the next degree, then the next degree, and that's it. And then for 20 years, you've not done anything. You've just worked the same thing again and again. That's not good enough. You need to keep learning something new every time. Keep learning a new language, a new hobby, read a new book, pick up a new habit, good habit, not a bad habit. So yeah, that's what I mean by education. And occupation also, same thing. Again, I don't mean keep changing your occupation, keep progressing in it. It's like you can't get stuck for like 20 years as the same occupation, no growth, nothing, keep doing the same thing. Does not work, right? These are the people. So people who get stuck. Simran, is that line? Oh, okay, fine. So yeah, so people who get stuck with their education, like they get, like we all study till 25 years and then after that we stop studying, we stop learning new things because we get tired of the education system, and that's not a good habit. We should always keep learning. Same thing with occupation, keep trying to progress forward, keep trying to do new things, within the same occupation if you can. If not, move on to the next one. So a stagnancy is bad for the brain. It's like a muscle. The more you use it, the better it works, the longer it stays in function. It does not rust away, right? Like the other part is lifestyle. So social activity, good for the brain. Interaction with other people, very good for the brain, right? Again, social activity does not mean going and drinking and partying and not sleeping well. That's not what I mean by social activity. Talking to people, interacting with people is good for the brain. That's as simple as I can make it. Physical activity, very good for the brain. Exercising regularly, at least 30 to 40 minutes of moderate to high intensity exercise is required for you to be able to maintain a good brain activity. And when I mean 30 to 40 minutes of moderate to heavy, in the sense, at least a brisk walk of 30 minutes, which means you cover 3 kilometers in 30 minutes at least. That's good physical activity, right? And I'm talking about the preventive aspect right now. The same thing can be used in treatment also with the non-medication side of it, but this is much better as a preventive method. A healthy diet, again, fats, cholesterol, while they are now no longer harmful to the heart according to certain studies, they still do get deposited in blood vessels, and they still will cause damage to the brain or to these other organs. So reducing fats, you know maintaining good sugar levels, eating healthy, eating uh, there are some certain oils and fats, like almonds are known to improve the cognitive reserve. So certain things like that, keeping them in your diet on a regular basis. And lastly, substance use of any kind is detrimental, right? I've heard so many people saying, ha, nicotine smoking is preventive of Alzheimer's. Please try to understand that nicotine smoking is not preventive of Alzheimer's. It helps, or it reduces the chances of one of the mechanisms mentioned before. One of the mechanisms it reduces, but what of the others? It causes vascular damage. It is a risk for stroke. So what about all of that? What about your lungs? What about not enough oxygen reaching your brain because you're smoking? So I've heard that argument so many times. That's why I pointed it out. But otherwise, also, alcohol causes direct damage to the brain. Other substances, hallucinogens, other sort of drugs, all of them cause damage to the brain directly or indirectly. So substance use is something that should absolutely be cut out, especially if you're already at risk, in the sense you already have a genetic preloading, right? So I would really like you to keep cognitive reserve in mind and start to practice it in your daily living. Also try to inculcate it in whoever you're taking care of right now, to whatever extent you can. So starting them off with a new hobby. Old people before used to knit. I mean, I have seen so many old people knitting when I was a kid, and now that I read about it, I realized, yeah, that was an activity. It was a physical activity which required creativity, which required judgment. you know it was a new thing that they would learn, and they would keep doing it, so it maintained their cognitive reserve. So yeah, things like that you should keep doing. Yeah, I think that's about it. So thank you so much. You can contact me through any of these ways if you have any further questions after this discussion. I think I've overshot my time excessively.
That's
as I usually do, as I always do. But yeah, we can have another 15 minutes of discussion.
Yeah.
Is that okay, Kriti?
Yeah, sure. And I think the presentation was really insightful. I'm sure a lot people have a lot of questions. So yeah, if you have any questions, please put them in the chat box. We can start off with Surjodev's question from earlier.
Yeah.
Yeah.
So the thing is, okay, before we do that, I'm really sorry if it got very technical. So please feel free to ask me, questions of terms that you did not understand, because I would really like it if you understood what I was talking about. So first question that Sujadeep asked, that, whether it's like a stroke. So I'm going to break it down very simply. Stroke is of two types. One is that uh, either it can happen because the brain is not being supplied by enough blood, or there's a break in the vessel and the brain has sudden sort of exhumation of blood, which is now causing damage to the areas around, right? So stroke can be of two kinds. The first one is called ischemic, the second one is called hemorrhagic. We're going to put hemorrhagic aside because it's not related, but an ischemic stroke is, yes, similar to what I said, but again, what I said is a long term thing happening. So this this is why hypertension can lead to strokes. So that's one mechanism of a stroke happening, but there are also other mechanisms, like there might be a blockage within the vessel, so the blood is not able to pass through, right? So it can be a thrombus or an embolus which is blocking there, or there might be narrowing of blood vessels because you have cholesterol deposition, because of which not enough blood is going. This is just one more mechanism that can lead to a stroke. So yes, stroke is very, very important for dementia, and stroke is responsible for a lot of dementias.
Surjadev has a follow-up question. Why is it just the ventricular system that exerts hydraulic pressure as opposed to arteries?
So okay, that's got to do with how the structure is. So arteries usually have elastic tissue within it. So say this is the wall. Within the wall there's an elastic tissue and then there's a covering around it. So even if this expands or goes down, it always usually comes back, which is why what happens in hypertension is it goes up like this, and then because there's constant pressure, the elasticity goes down and then it collapses. With the ventricular system, it's not placed in a similar manner. The ventricular system is sort of like, you can keep filling it as much as you want, and it has too much of elasticity, but it also has plasticity. So it fills and then maintains the shape. It does not come back. That's the problem. So it's constantly applying pressure on the brain, but when our brain is absolutely all right, the brain is able to apply enough pressure against it. If our brain now starts to lose its strength, as will happen as you're aging, I mean, you can't have the same muscle power, or you can't have the same uh, rigidity as a normal person does. This will now start to push and start to expand and take up more of fluid, and that's why it sort of leads that. So it has an elastic component, but it also has a plastic component. It's constantly expanding.
Next question. Upal asks, how to help someone who is not able to find the right words to express themselves?
Okay. Right. So I will ask a couple of questions back because I want to give you the right answer. So if we can just unmute him or her for like a minute. Okay. So I'm sorry,
I have done
forgot
the
her name.
unmute.
Hi, ma'am. So my question is this: that is a person able to understand everything you're telling them?
Just repeat your question, please.
Are they able to understand everything you're telling them?
Yes, to almost, I mean, almost 80-90% of the things what we tell them to do, they understand.
Mm-hmm. Right, ma'am. So when someone is very specifically having word finding difficulties, it's always a good idea to give them suggestions, let them not struggle too much, but also not give them the whole word. That is when it is happening. As a preventive measure or as a measure of stimulation, what you can do is simple activities like what we do with kids, get pictures, show them the pictures, and every day ask them to identify the pictures as a task. So it can be a fun related activity also, right? And you can keep telling them, for example, telling them in the sense, don't make it very obvious, but things like, Acha, why don't you eat the rice with a spoon? Why don't you take the plate and put it in the sink? So these sort of things. So you use the words in your everyday life. and that keeps reminding them that this is called a plate, this is called a spoon. Same thing with names also. You use the names on a regular basis. The more it is used, as I said, the more it goes in that circuit, the better it is stored. So using them
It was the
on a regular
starting
basis.
symptom. It was the starting symptom. It was
Right,
the
ma'am.
main symptom.
Yeah.
And then other symptoms appeared slowly. I mean,
Right,
once
ma'am.
we had a look from that angle, I'm
Hmm.
myself also a doctor, and
Yes,
he's
ma'am.
also a doctor.
Yes.
And but now the stage has come that he uses this, that, and that becomes,
Very
difficult
confusing.
for me to understand, and that frustrates him when I can't
Yes.
understand.
Yes, ma'am. So these are certain, I mean, if you can convince him to do these activities on a daily basis where he's shown
That we are
objects and he names it.
doing from Asha, we are doing 2
Mhm.
classes in
Okay, okay,
Zoom.
okay.
He's comfortable to talk to them.
Hmm.
He's, socially he's comfortable in how are you? I am fine, thank you. But more than that, if he tries to talk, the other person can't make head or tail.
Right. So
And
he has a naming difficulty.
just I want to know, does this then, till now he's very smiling and a laughing person. He'll laugh when he can't remember.
Right.
But does that progression of this symptom, does it lead to anger or something like that?
It can, ma'am. I mean, see, it's basically like it's a frustration that builds up that I was
Frustration
able to
is
do it in the
now
past.
starting.
Yeah, yeah.
Frustration is
So,
now starting,
yeah. And
anyway, I just wanted to
yes,
know
ma'am.
if, I mean, I have just started putting, pasting with the sticking this thing,
Oh,
names
wonderful,
on the
ma'am.
things, which
Wonderful.
is usually toaster,
Yes.
fridge, this
Yes.
thing. This I have started putting
Wonderful. Wonderful.
so that, but I don't know what else one can do.
It's difficult, ma'am, and I understand that.
And
But
how much
you're going in the right.
is the genetic factor plays a role in it, because his
To
mother
be
had and my father had, but they all had a later age than
later.
this.
Yeah. So there is
I mean,
something
that
that's
was,
called as, I mean, you know the term, there's a term called where it comes sooner in the next generation always. That's always the case, and which is why your prevention needs to start at a very early time. And so the genetic factor is quite strong, especially if it is Alzheimer's. But there are other dementias like frontotemporal dementia also, where it becomes very strong.
this is frontotemporal
yes, frontotemporal.
atrophy.
Yeah,
This
that's
is
what it seems like,
frontotemporal.
because it
But I just
started with
wanted to know the area is in frontal this thing, or I mean,
this
it is
area.
fronto.
Yeah, so this area is at the junction of the frontal lobe and the temporal lobe. It actually comes closer to the parietal lobe, but it's the connection between the frontal and temporal. So the Broca's area and the Wernicke's area, the connection between those, that's where the damage usually happens in anomia.
I wanted to suggest you had a very good slides, but
yes,
what we could see even on the best laptop, we couldn't read, and we really couldn't see the pointer, and we couldn't see the, I mean, if there is any system, you all are, I mean, IT people are there to help you. If we can, if we can increase by using our fingers, if we can increase the bottom slide which we want to see, or you can post us the, you can email us those slides. We can, in a way that we can increase them and read it.
Sure.
I mean, I'm a medical person. I could judge it, but I'm more inquisitive to read it.
Right. I will share the slides, ma'am. That's not a very big deal. I'll just share the slides with. I'll just ask them to mail it to everyone. Not a big deal.
And will you be having the recordings of the sessions also? Because previously I couldn't join on the first day. Today the link was easy to join, so I could join it.
Kriti, we have a recording, right? We'll be sharing it with them.
We have the recording from last time as well. We'll share that.
We'll do it, ma'am.
Okay, thank
All
you
right.
very much. Thank you.
Thank you, ma'am. Yeah, can we move to the next question?
Yeah, I'll just take a couple more questions in the interest of time. So, okay, when we keep learning new things, does that mean new neurons get formed in the brain?
It's not new neurons, it's new neuronal connections. So the circuit, so these neurons are already present here, right? These neurons already have a connection. The connection between them gets stronger. There's more neurotransmitters going through, so they get more adept. The problem isn't whether this connection is already present. The problem is if you don't use it, this connection will slowly start to taper away and break off. So if you keep using it, it remains better. When you learn new things, you're using the same neurons in a different manner, and that keeps it excited. Right? So that's how it helps. Yeah.
Next question, Sojodev asks, can the damage of not getting words be repaired back? Is this anomia specifically?
Okay, anomia is very specifically with just naming objects, and then again, it can be different things. It can be with naming objects, or it can be with naming people, or remembering names of people, whatever. So I will not go into the technicality because it's difficult. I don't want to go into that, but very simply, this sort of naming problems and these sort of um, remembering word finding is a very difficult thing to reverse. You can get it right to a certain extent. It's not reversible. Let me make that very clear. It's not reversible, but if repeatedly inculcated into them, that as what ma'am is doing, labeling or repeatedly using them in sentences, they do pick up on it sometimes, and then they just on pure memory they use it. So the function that has gone is gone, but now just on pure memory they do it. So it will keep worsening, but you can reduce the progression. You can slow down the progression. Yeah.
Lastly, Vanita asks, is there any medical treatment available for word identification?
So, ma'am, unfortunately, dementia does not have a symptom-based treatment here. Very honestly, it's like throwing darts at a dartboard. There are very few medications available, and what these medications do is work with the neurotransmitters rather than work structurally. So we don't know where it works. It just increases the neurotransmitter levels in general, or increases the flow through circuits in general. So whichever area is less damaged. So when we talk about dementia, I always like to talk about it like a shadow. So there's a dark area of the shadow, and then there's a gray area of the shadow. The dark area of the shadow is really nothing can be done about it, even with medications or with therapy. The gray area of the shadow is where you can expect things to get better, but again, there is no guarantee. Even with medications, I've seen a lot of people improve very significantly also, and I've also seen people hardly improving. So it really is very subjective. So we can't really focus on one area and say that, bullseye, I've hit that area and that's going to work. We just give medications, and then things improve in general. With therapy, you can focus much better on such areas.
Okay. I'll just take one last question from Abhishek. So as the disease progresses, wouldn't learning new things become very difficult? Do you suggest this for the early stage or even the more, even moderate stages?
I would suggest it for the very early stages, because they become very resistive to learning new things, so it's very difficult for them. And I totally agree. So, but rather than at this stage, when it goes on to a moderate or a severe stage, learning new things need not be like completely new things. It can be relearning old things, which seems new to them. So, for example, someone who, say, as the example, let's take this example itself, since we are on this naming part, someone who's forgotten to name things. Now, reteaching them to name things is something that can be a new experience for them. So, doing the same thing again and again in a new activity till they learn it, then moving on to the next thing, right? So simple tasks, and it's always better to combine a motor task with a cognitive task. So uh, as I said, knitting, it requires creativity, but it also requires coordination with the fingers. So things like this are very helpful. Even simple things like peeling a pea, putting it in curry, peeling up garlic, very, very simple activities, but they work to help functioning the brain. I saw that question, so I'm going to answer is yes, singing can have the same effect.
Okay. Thank you so much. I see there are still a lot more questions in the chat box. So I think you can, we'll put Dr. Abhimanyu's email in the chat and you can reach out to him directly if you still have any questions.
What we'll also do, Kriti, is compile a list, send me the questions. I'll just drop in an answer and then it can be shared with the whole group.
Okay, sounds great.
Huh?
Simran,
Yeah.
Okay. Yeah, thank you so much, Dr. Abhimanyu, for this informative session. I think we all learned a lot from it. We'll also be adding a feedback form in the chat, so please fill that out. It's just 3 questions. We want to keep improving ourselves. Thank you so much, Dr. Abhimanyu. One last thing before we go, just a plug for our next session. One second. We'll be having a very interactive session with Neha from EPOCH Elder Care. She's the CEO and co-founder of the organization. And this will be a very just like informal interactive session where everyone can kind of share their experiences with dementia and kind of connect with each other, and Neha can provide like practical tips and advice on how to deal with your different issues that might come up. So please do come for that as well. We will send you the link if you've already signed up. Thank you so much for attending. Thank you, Dr. Abhimanyu, once again. Yeah, it was lovely to have you. See you.
Thank you, Kriti. I see you.
I think you can switch off the recording.
Simran, I have put all the questions in the channel so that you have all of them.
There's an option to save the chat as well.
Oh, great. All right. Thanks.
It's still recording, I think.
I think you'll have to